We want to get right into our program, and so I want to introduce our first speaker, Ms. Amy Doneen, is from Spokane, and she's an international leader in preventing heart attack, stroke, diabetes. She has a strong focus on women's heart health, utilizing her skills to define risk assessment and treatment. Since 2002, she has given more than 600 presentations and counting to global medical groups, including the International Atherosclerosis Society, the International Symposium of Atherosclerosis, National Lipid Association Symposium, the Women's Heart Symposium, American Heart Association, Berkeley Heart Lab, Cleveland Heart Lab, and the American Academy for Oral Systemic Health. She's been interviewed for major radio and TV shows and has been published in regional, national, and internet publications. Amy is owner and medical director of the Heart Attack Stroke Prevention Center in Spokane, Washington, co-founded the Doneen Method for Heart Attack, Stroke, Diabetes Prevention. She presents AAFP accredited continuing medical education preceptorship courses several times a year in cities across the United States, training healthcare providers in such advanced cardiovascular disease detection techniques as genetic testing, state-of-the-art ultrasound measurements and major arteries, high-tech heart scans, personalized treatment strategies, and fire panel tests for insulin resistance, which are cornerstones of the Doneen method. She's the co-author with Dr. Brad Bell of the recently published book, Beat the Heart Attack Gene, and is an adjunct professor at Texas Tech University Health Science Center School of Nursing, and has delivered numerous keynote addresses on women's heart health and major medical conferences. She's also a member of the Society of Atherosclerosis, Imaging, Prevention, Heart Attack Association, American Stroke Association, Coalition for the Diagnosis and Treatment of Peripheral Artery Disease, and National Lipid Association, and others. It is now our pleasure to learn from the incomparable Amy Doneen from nearby Spokane, Washington. Thank you.
Okay, am I on in the back? I am? Thumbs up? All right. Lee, thank you so much for that kind introduction. I appreciate that very much. Thank you all for being here, and thanks for having me here. Boy, what a nice group. You all look awake, and boy, Tri-Cities has it going on, I'll tell you. Boy, oh boy, oh boy, what a great group. Well, I am very honored to be here for a number of reasons. One, I really believe in building bridges. I think that if we want to do a good job and prevent heart attacks and strokes, we need to pay attention to the whole body. That's the tip of the head to the tip of the toes. And my focus clinically is something called Artery Ology, which is the science, the study, the focus of the highway system in our body. We have 60,000 miles of vessels that feed nutrients to every organ that we have: the brain, the heart, the kidneys, the liver, the toes, the nose, the teeth, the eyes. And if we all do our job right together, and we all come at this with a different knowledge base, right? And if we all bring that knowledge to the forefront and say, we're going to do everything today that we can to keep those highways healthy, we can live a life of wellness. What a great opportunity that is. So those diseases of aging that we so kind of expect in today's medical world, such as, oh, I don't know, microvessel dementia. How about macular degeneration? How about heart attacks or strokes? They're somehow accepted in this society as something that may just tread on our territory, and I am here to say those do not need to happen. But in order for those not to happen, we need to join forces. That is, medicine and dentistry need to start working together to communicate and say, hey, we need to do a better job at mitigating one thing. And do you know what that one thing is? Inflammation, right? We all need to reduce the inflammation inside those highways so that we reduce the chance of those highways being blocked somewhere. So what I want to do today is talk about that concept. Now, in our book, this is my colleague, Dr. Brad Bale, who I'm going to fly off to and meet and lecture with tomorrow in Las Vegas. But our book, Beat the Heart Attack Gene, is written to you, it's written to your patients, it's very tangible, it's very readable. So I encourage you to get it. I brought some with me here today because it will tell the story that you are talking to your patients about every day. And I'll share with you at the end of my talk today a story about one of the patients that's highlighted in this book. Her name is Julie. So let's just get on with it. Let's talk about this oral systemic connection that we're going to discuss all throughout the rest of today. So the outline for today is really to first touch on the magnitude of this disease state called atherosclerosis, and also the magnitude of periodontal disease. Because quite honestly, if you take cardiovascular disease and periodontal disease, those are the big whammies out there. They are the most common chronic diseases that face us as humans, period. So let's talk about them. Let's talk about them, how common they are and what they're costing this country. Let's also talk about red flags. Red flags, I can't talk about all of them. I give a 2-hour lecture just on red flags. I'm going to touch on just a few because when you do your health and physical forms in your office, I want you to start thinking a little bit differently. If you see something like psoriasis on a health form and you think, oh, they have psoriasis, I don't want you to just think they have psoriasis. I want you to think, wow, they have a systemic autoimmune condition, placing them at risk in their lifetime for potentially a heart attack or stroke. I better make sure they're in that dental chair every 3 months for a cleaning, and I better, while they're sitting there with their mouth open, they can't talk. That's a prime moment of education. I better talk to them about psoriasis and inflammation and the fact how important it is that they floss every day. So I want to talk to you about some red flags, okay? Then I want to talk about event reality. What really causes a heart attack or stroke? Because believe it or not, patients who go in and have a major heart attack sometimes leave the hospital and don't even know what just happened to them. So I want to give you a very succinct dialogue for you to have with your patients in about 3 minutes so that they get it and they understand the importance of flossing and brushing and paying attention to their health on a maintenance standpoint. The global understanding of inflammation, I want to touch on that a little bit. You're thinking, how's she going to do that in 2 hours? I will, I promise. I'll get you out on time. I want to also talk about then the root cause of vascular disease and vascular inflammation. And I'm going to highlight the oral systemic connection. That's a main one I'm going to talk about. But I'm going to talk about a couple more just to show you. The oral systemic connection is one of many. But I'm going to highlight the oral systemic connection. And then I'm going to succinctly bring it all back home and introduce you to a very wonderful woman. Her name is Julie, and introduce you to her, how all of this plays into real life. Okay? Y'all on board for that? You ready to roll? All right then. Okay. So I just did this on Monday. So was anyone there with me? Anybody? Yay. Yay, you were. Were you there last year too? No. So it was a great race this year. I was there last year in the bombing, caught in the mix of it, and I was there the previous year as well. So this year was a great, peaceful, very celebratory race. So I'm very honored to be here, and it definitely was Boston strong. So what a great moment that was to cross the finish line, because last year I did not get to cross it. So it was great. So congrats to you. Did you have a good run? Oh, you weren't there. Aw, I thought I saw you there. Okay, all right, well, let's move on. Okay, so current American Heart Association statistics. Every 30 seconds, 34 seconds rather, while I'm up here talking, someone in this country is going to have a heart attack. Every 34 seconds. Every 40 seconds, someone in this country is going to have a stroke while I'm up here talking. Average numbers of years of life lost for one heart attack is about 20. You will lose, on average, about 2 decades of life lost unless, heavy on the unless, something is done differently for that individual patient, because 50% of heart attacks are recidivistic, meaning people are going to go and have another one, and 50% of those recidivistic events are fatal. So the problem we have in this country is a real big one. People who have a heart attack, unless we stand back and say, oh my goodness, what caused the plaque in your arteries in the first place, then they're going to have another one. And they have a 50% chance of that next one being fatal. Can you imagine if the first one was caused by periodontal pathogens and that patient didn't have the opportunity to know that, and that periodontal disease infection was left to continue and smolder, even though that patient was placed on a statin, a beta blocker, an ACE inhibitor, an aspirin, all those things, and they still had a chronic infection that was driving inflammation? Can you imagine the travesty of that? So they get to retirement, and those 2 decades that they planned to travel and do all those things they wanted to do are gone. It's terrible. 64% of women and 50% of men who die suddenly of a heart attack didn't even have the wonderful knowledge to know that they had plaque to begin with. Current data, this was published 2 weeks ago. This is the most current data. How many of us in this room are either between the ages of 55 and 64 or know somebody between the ages of 55 and 64? Oh my gosh, everybody, really? So we all know somebody who has the highest risk of having a heart attack. Seriously. So how relatable is this condition? Wow. What about periodontal disease? Data from 2010. 50% of Americans over age 30 have periodontal disease. This stuns me. 70% of Americans over age 65 have periodontal disease. This is one of the most prevalent chronic diseases out there, I am learning. Shocking. It's even more common than heart disease. How much is heart disease costing our country? A lot. Looking at the projected statistics, 2015 to 2030, unless we do something different, we're aiming to spend $1.2 trillion treating an end-stage disease platform. Meaning, when someone has a heart attack or has a stroke, we throw all these resources at them if they survive that event. It is bankrupting our country. Bankrupting our country. We've got to do something different. So whose job is it? Is it just mine because I have a shingle on my door that says, hey, I treat heart attack and stroke prevention? I would argue it's all of ours because we all have the ability to treat inflammation. And that's the keystone to this whole disease state. So I would argue anybody, whether you come at this as an OBGYN, whether you come at this as a nurse, whether you come at this as a dental hygienist, a dentist, a surgeon, I don't care how you come at this disease state. If you have the chance to impact inflammation and reduce stress, so if you're a psychologist, if you're a counselor, if you know how to teach yoga, you have a chance to reduce inflammation in an individual patient. It's your job to reduce heart attacks and strokes. It's your job. So let's talk a minute about some red flags. Now, red flags are things that are really interesting to me because red flags are not only just to point at other people, but red flags are the chance to take a mirror, hold it up to yourself and say, whew, I wonder how many of these things I'm dealing with. Because red flags are those things of humanity that are comorbidities, that if we have these, we may just flat out have a higher risk in our lifetime of developing plaque in our arteries. We may have not asked for them, we didn't cause them, we didn't do something wrong to get them, but gosh darn it, if we have these, we have higher risk than the average individual of developing plaque in our arteries. Now, red flags do not necessarily have a cause and effect associated with them. By that I mean, if we fix the red flag, it doesn't mean that the cardiovascular component is going to go away. An example of this might be a migraine headache. That is a red flag. If you have migraine headaches upon history, you do have an increased risk in your lifetime of having strokes and heart attacks. Does that mean if we cure your migraines, the risk goes away? Not necessarily, because we don't know the exact mechanism there. But if you see somebody, one of your patients with migraines on history, pay attention to them. Make sure they are assessed carefully. So let's talk about some of those red flags. They're everywhere. Sometimes they're really glaringly obvious. Sometimes you have to shift your perspective a little bit and say, wow, I didn't quite realize that. So let's talk about some of these, but they're there and they're there in full force. There's lots of them. I'm only going to bring a few up to your attention just for the sake of time. How about rheumatoid arthritis? Do you know that a rheumatoid arthritic individual is just as likely to die of a heart attack as a type 2 diabetic? And a type 2 diabetic is considered a coronary risk equivalent. I think, based on the data that has been mounting with RA, that an RA patient should be just as likely or should be considered a coronary risk equivalent. So think about these a little bit from a business standpoint. So if you run a dental practice and you propel yourself to be a oral medicine specialist, you should be going to the rheumatoid societies in your communities and saying, hey, I'm a dentist, but I specialize in inflammation reduction. You all who have rheumatoid arthritis have a lot of inflammation. Let's talk about how I can help you with that from treating oral inflammation. So get to those rheumatoid groups and talk to them about this association. How about psoriasis? How about this idea? Is it always unique that someone would just have psoriasis? Not necessarily. We can look at any of this data, whether it be psoriasis or lupus, systemic lupus erythematosus. If you think about that condition, I don't have the slide up for you, but if you couple psoriasis or lupus with hyperlipidemia, the risk goes up to 16-fold that in their lifetime they will have a heart attack. So you couple these autoimmune issues with other cardiovascular risk profiles, and their risk goes up exponentially. How about not autoimmune issues? What about the idea of your patient going in for cancer therapy? This happens to be data on post-breast cancer therapy. What are patients dealing with when they go in for cancer treatment? They're dealing with a brand new platform of risk. Usually they're on high-dose steroids. Their weight is going to fluctuate in not a good way. They're going to be psychosocially very, very challenged, scared. They're not going to sleep. Their exercise is going to change. They're going to be on medicines that are very detrimental to the organs, such as the heart and the kidneys. So wouldn't it be a good idea to set them up successfully for their cancer therapy? Make sure that they have no inflammation from head to toe prior to going into this life-altering state that they're about to enter into. So breast cancer therapy patients need to make sure and see you as a oral medicine specialist and a provider who treats inflammation to make sure they are set up for success. The last thing someone needs is to have a stroke or a heart attack when they're in getting their cancer treated, which happens a lot. The inner heart trial. 33 different countries, 55,000 different people. What causes a heart attack? They looked at everything. They found 9 risk factors that predict 90% of acute coronary syndrome. Number 1 on the list were the lipids, but LDL didn't even make the list independently. It was total cholesterol divided by HDL. That, or ApoB divided by ApoA1 was the proper way to say that. But anyway, lipids were number 1. Number 2 was smoking. You know what number 3 was? Psychosocial. That trumped diabetes, that trumped diet, that trumped exercise. So stress, depression, lack of sleep, psychosocial is high on the list for heart attack prevention. And believe me on this definition, the best definition that I have learned about from my psychology and psychologist colleagues is this. Stress, as it relates to vascular activity, is to be in an environment for which you perceive a lack of control. If you perceive a lack of control in your environment, whatever that environment is, it's not going to be healthy for your body. So work with your patients to make sure they obtain a good perception of control. Now that control could be way off base. Doesn't matter. As long as they perceive they're in control, the vessels appreciate that. That's why Donald Trump probably isn't stressed, but everyone around him is freaking out. Right? So, okay, here's another one. Here's another one just to talk about the psychosocial issues. How about spouses who care for partners who are terminally ill? Those poor spouses and loved ones who are offering care day in and day out are more likely to have a heart attack or stroke significantly. They looked at them at 1 year, 1 to 5 years, Post 5 years, they looked at males, they looked at females. Males had the highest risk within the first year. Women had the highest risk within the 1 to 5 years. It was not mitigated post 5 years, but it seemed to balance out a little bit. So you've got to make sure that you're caring for the loved ones who are caring for somebody at home, because the last thing that needs to happen there is this caregiver has a catastrophic event. So depression and stroke risk, the data stands that if you are suffering depression, you've got a 41% increased risk of having a major stroke. That's a big deal. What about just specifically women? What are some red flags for just women? How about this? Women with migraines with aura on history have an increased likelihood of stroke later in their lifetime. Women with migraines with aura on history have a higher lifetime risk of stroke in their lifetime. Women with polycystic ovarian syndrome have higher cardiovascular risk in their lifetime. Preeclampsia is an indicator of cardiovascular risk. This one really gets my attention, because the data suggests that that woman who dealt with a pregnancy that was riddled with fluid retention, blood pressure changes, protein exchange through the urine, a very dangerous condition for her and the baby. Once the baby's delivered, she heals, she's okay. 10 years, when that child is now starting 2nd grade, she is at a 2-fold increased risk of suffering a major cardiovascular event. When her child's hitting 2nd grade, she's not even thinking cardiac at that point. Can you imagine? She forgot that she had preeclampsia probably during her pregnancy. And then the venous thromboembolism is at a 2-fold increased risk when that child is in kindergarten. When she takes that child to Disneyland and sits on an airplane for 5 hours. So you understand the magnitude here. When this data came out, the suggestion was if any female has preeclampsia, she needs a full cardiovascular workup 3 to 6 months post-pregnancy. Is that done routinely? No. Should she see her dentist and hygienist once a year if she had preeclampsia, or maybe every 3 months? How about every 3 months to make sure she doesn't have any inflammation stemming from here? Wouldn't that be a good idea? Well, I don't know, for the rest of her life? Yeah, it would be. Gestational diabetes and cardiovascular risk is a red flag. For sure, it's not a matter of when, or it's not a matter of if that woman will get diabetes, it's really a matter of probably when. What about men? Are there some specific data with men and red flags? I would say yes. How about this, just to make your mind think a little bit differently? Those brothers of the women with preeclampsia, well, with PCOS, sorry, the brothers of the women with PCOS are also at cardiovascular metabolic risk themselves. That's a shocker, isn't it? Men just don't have ovaries to demonstrate the same sort of issues, but they have the same metabolic cardiovascular issues as their sisters. Interesting, isn't it? Migraine on men with history. There's no aura data with men, but there's migraine history with men. That's a red flag. So red flags are everywhere. You just need to be willing to look. And in our book, we talk about a lot of these. There's a lot of red flags that I don't have time to go into, but look in the mirror. If you've got any of these red flags, you need to stand back and say, whoa, I better find out if I'm okay. So how do you know if you're okay? Let's say you have rheumatoid arthritis, or let's say you had preeclampsia during a pregnancy. Let's say you've had a migraine before. How do you know if you're okay? So I'll tell you something. Here's what the standard of care does. The standard of care pulls out a calculator. The standard of care pulls out a calculator and it does some things. It says, okay, Amy, you're 44 years old, your cholesterol is this, your blood pressure is this, your good cholesterol's here. You have an X% chance in the next 10 years of having a heart attack or stroke. Mine happens to say I have a less than 1% chance of having a heart attack or stroke over the next 10 years. Well, is that good? Is it bad? I don't know. Here's the challenge. Using the Framingham risk calculator, which started in 1948 and is still used today. Matter of fact, they just modified the guidelines December 13th, 2013, so 4 months ago. They just modified the guidelines, but they're still using this calculator. They're still using the same calculator, but they're getting more strict. They're saying, well, if you have a 7.5% risk over the next 10 years, you know what we're going to do? We're going to put you all on a high-dose statin. That's what we're going to do for you, based on your risk profile. Well, hey, is that fair? Maybe you don't have plaque, maybe you do. Should you be on a high-dose statin for your whole life? I don't know. But I really think that's a risky drug. I would hope you wouldn't have to be on a high-dose statin your whole life based on a calculated risk. I want to know if you're okay. It's no different than in dentistry, sitting in a chair and me asking you questions and filling out a form and saying, okay, how often do you brush? Okay, twice a day. Okay, well, do you floss? And the patient may say, oh, no, I never floss. Okay, that's 1 point. Do you have any cavities? Yeah, maybe I have 4. Okay, that's 4 points. Okay, it looks on here that you have a 3% chance of having a cavity. Yeah, okay, well, I'll see you in 6 months. Did you even look in the mouth? It's no different than this. Do I look in the arteries to know if there's plaque using a risk calculator? No. Do I look at the inflammation to know if there's inflammation using a risk calculator? No. And this has been challenged over and over again, and they've tried to do it better. They've now done the Reynolds risk score, which adds into it a couple things, a HSCRP and a little bit of family history, but only if your mom was under 65, and only if your dad was under 55. If grandma and grandpa or your brothers or your sisters or aunts and uncles had an event, forget it. Only if mom and dad were under that age. And if your mom was 66, forget it, she doesn't count. Right? You can't do that. And we're still missing a lot of people. This is a 20% high-risk individual using a Reynolds risk score. Only about 61% of people are picked up, so we're still missing about 39% of people who've had an event. We're still missing them. Dr. Okasa in 2002 did the guidelines, the calculated guidelines on people who had a heart attack. Let's say all of us have had a heart attack. Let's do the calculator on all of us. We missed 82% of the women and 66% of the men using that calculator. What do you think about that? It's terrible, isn't it? Do you understand why if we don't do something different, we're looking at a $1.2 trillion expenditure because we're going to catch these people in a shock mode? Kind of like gambling in Vegas. Let's roll the dice. Are you at risk? I don't know. Are you okay? I don't know. You look fine on paper. So let's look at this a little bit different, shall we? So that's what my colleague and I did about 13 years ago. We said, well, hey, what really causes a heart attack? What really causes an ischemic stroke? Let's do something different. Let's not just rely on risk factors because those seem a little bit tenuous. Let's look at another way. Let's say, okay, 1, do you have disease? 2, what caused it? 3, how inflamed you are. And you know what? If we treat the why, we see the inflammation go down and we see the disease stabilize. It's a pretty simplistic approach, but it's a different approach. So I want to talk to you about that now, and I'll show you how the oral systemic connection fits into that approach. So first off, let's talk about what causes an actual ischemic event. I call this eventuality. What causes a heart attack or an ischemic stroke? You know what it is? It's a blockage of blood flow. That's of no surprise, right? But the big aha moment is what causes that blockage of blood flow. It's not cholesterol that blocks slowly the opening of the artery. It's not cholesterol that just slowly collects inside the opening of the artery here. Plaque lives in the artery wall, like this. And it's virtually out of sight, out of mind, until we have a problem. And that problem is really driven by an inflammatory crisis of some kind. It could be a periodontal infection, it could be an endodontic abscess, it could be LDL oxidation, it could be cholesterol, it could be obstructive sleep apnea, it could be nicotine, it could be all kinds of things. But if there is an inflammatory crisis, that protective layer over that plaque called the endothelium can rupture. And the plaque underneath it is exposed to the blood flow, and the body says, oh, hey, we know how to fix that for you. We'll just heal it with a blood clot. And that blood clot, otherwise known as a thrombus, is usually going to block the flow of blood somewhere. And if it blocks the flow of blood in the heart, we'll call it a heart attack. If it blocks the flow of blood in the brain, we'll call it a stroke. More often than not, though, it blocks the flow of blood in little tiny vessels that we don't feel and doesn't make an announcement. It blocks the flow of blood in vessels that are no bigger than a human hair. And it happens year after year and decade after decade until our parent or ourselves, we get to be 85 years old and we can't remember things anymore and we get called demented. Or we can't feel our toes anymore and we have peripheral arterial disease. Or men struggle with erectile dysfunction. Or we wind up on dialysis because our kidneys aren't getting proper blood flow anymore, or oxygen. So those are diseases of aging, but it's caused by the exact same thing called atherosclerosis. So here's something I want to show you, another concept with this whole idea. Do you know anyone who passed something like this? It's called a stress test and then had a heart attack. How about like Tim Russert, right? Remember Tim Russert from Meet the Press? He gets on his treadmill. Gets on his treadmill in April, passes it. Does great, actually. Cholesterol looks good, blood pressure looks good. 2 months later, he's in his office, getting ready to probably do something really important for those of us who don't know politics. He's going to tell us all about it. Drops dead in his office. 2 months after passing one of these fancy-dancy tests. How on earth did that happen? That guy's famous. I mean, how did that happen? What people don't understand is they say, what? How do you pass a stress test and have a heart attack? It doesn't make any sense to me. Here's the reality, you guys. In order to fail a good old-fashioned stress test, you need at least a 70% blocked vessel. However, 86% of heart attacks occur in vessels that are less than 70% occluded. The plaque is smarter than the technology designed to find it. This stress test is designed for people who have symptoms, and there's lots of great reasons to do a stress test. If you're short of breath, you have chest pain or something like that, do a stress test. But to look for silent plaque in the wall of the artery, you're not going to find it, because it's looking for the flow of blood, not for plaque in the artery wall. So understand that. The plaque is smart. It hides here. It doesn't present itself with a big, flag. Hey, here I am. I have yet, in 15 years of doing this, have someone come to my door and say, hey, Amy, I think I'm growing fatty streaks and plaque development in the wall of my artery. Never happens, right? Because we don't feel it unless there's a problem. And there's only a problem when this happens. And then we hear about it. And if I do my job right clinically, if someone's got this, which a lot of people do, but not everybody, if you've got this, my job says I'm never going to let this happen, ever. Because I'm going to do everything in my power to monitor what's going on here and monitor what's going on here so that rupture never occurs. So I'm going to show you a little video of this so it can be understood probably a little better than I could show you. Oopsie, I may. Let's see. I'm going to turn it down, though, because we don't need the drama of the sound. So first I'm going to show you an artery. This happens to be an artery of the heart, but it could be any artery, you understand. First I want to go into an artery that's very healthy. And this is what a normal artery should look like. You've got a nice endothelial wall. These cells are nicely grouped together. You've got red blood cells, white blood cells, platelets. This is a very normal, healthy artery. And that's what our arteries should look like from head to toe. Now I'm going to shift gears a little bit and go into an artery that's got plaque, but the plaque is stable, so there's a difference. Here's, red blood cells, white blood cells, platelets. Here's a plaque here, but the difference is that plaque is stable. Now I'm going to show you an artery, I can't stop it, sorry, an artery that is active, that plaque is active, and you're going to see a difference here. Through that endothelium, you're going to see vulnerability, and you're going to see oxidized LDLs flip through this endothelium. You're going to see those macrophages try to gobble up those oxidized LDLs. They're going to congregate into foam cells. They're going to group together, and they're going to cause a rupture in this endothelium, and instantly the body's going to say, I can fix that. And immediately that clot then goes to repair that ruptured endothelium, and the tissue surrounding that clot or thrombus is not going to get oxygen, and we would call that a blood clot or a thrombus or a heart attack. Do you see that? So if we stent that area or bypass that area that was just blocked, we just put a Band-Aid on a 60,000-mile vessel rash, right? Because you've got that plaque everywhere. So if we repair one area and forget to do our job and ask why is the plaque there in the first place, we're missing the picture, because that rupture could happen somewhere else, right? So how naive is it to think if you just stent this and you fixed the whole body, it's going to be a problem, because that systemic atherosclerotic condition is going on everywhere. That's why this is a systemic disease state. So we need to think more globally, and we need to look at the whole body and treat all of these highways effectively. Now, the world of cardiology is doing an excellent job. The survival rate of a heart attack has never been better. Huge respect for the world of cardiology. Huge respect. They can get you from presentation to ER to cath lab quicker than ever before. They can stent, they can bypass, they can save lives like never before. But it's our job as prevention specialists to stand back and say, all right then, you had a heart attack. Why'd you have it? And we treat that why so it never ever happens again. How do you define an event? Certainly via heart attack and stroke, but think bigger now that you know it can happen from head to toe. Think all of these things are also what you're all about: preventing dementia, preventing macular degeneration, preventing end-stage kidney disease, peripheral arterial disease, etc. That's what prevention's really about. It's not just neurology's job to prevent strokes, cardiology's job to prevent a heart attack. It's our job to keep the highway system healthy. We call plaque a cat in the gutter. Do you know why? I'll tell you why. In 2006, my colleague and I, Brad Bale, were over in Rome, Italy. And the four of us, my husband Darren and I and Brad and Pam, we were all sitting there, and Brad and I had just presented some data. And we were like, God, look at, we were sitting there, and the gutters in Italy are square, like this. They're not like round here. They're square. And literally these pigeons are walking around happy, and people were feeding them bread. And these cats literally jumped up, and they were like getting these birds. It was awful. I was like, oh, oh, oh. Like I didn't want to see it anymore. And Brad and I said, hey, that's like plaque. It can jump out of that gutter at any time and claim lives unexpectedly. Those poor birds had no idea there's a cat in the gutter. They're just happily getting their bread, right? So we love that concept, the idea of saying, hey, what about the idea of trying to find a cat in the gutter? What about the idea of looking in our gutters to see if there's a cat in there? Because we don't feel it or see it or can't touch it until the cat jumps out. But we can find it in our bodies. So we have an illustrator. His name is Moss Friedman. He's out of New York. And so he has helped us make these illustrations. You'll see these in our book. But that's our cat in the gutter, and that's where that whole story came from, just so you know. So anyway, cat in the gutter. So traditional cardiology has been focused on lumenology, which is the study, the focus, the training, the techniques to keep that lumen open, right? So if you get a test done, and common lumenology tests would be things like a carotid duplex scan, an angiogram, a stress test. Those are tests to all tell you if the artery is open, and they're very important. But those tests are not designed to tell you if you have a cat in the gutter, because you know what? The cat hides here. And if we remove all, this is the same artery, this happens to be a carotid artery, but if we remove all of that picture and we just look at what we just focused on, that's what we'll see. So those are common lumenology tests. If your focus is arteriology, the same image, same artery, you're going to focus here. And so what you want to do is find out, okay, how do you find out if you have a cat in the gutter? Do you see the difference? So tests that measure for a cat in the gutter coronary calcium, there's many. Carotid Imt testing, which happens to be here, offered to you today. So I'm going to talk a little bit about that. Vasolabs is here, and huge thank you to Vasolabs and Joanne's for being here to volunteer to do that for you, because it'll save your life today. Huge opportunity to find a cat in the gutter. All right. So we must not limit ourselves by only looking at the 12 inches around the heart to find out if we have a cat in the gutter somewhere. That would be crazy, because we know this is a systemic condition, right? So carotid calcification, how about this idea, you guys? Here's one idea that I want you just to think about when you go back to work on Monday. This is looking at 77 males, average age 69, routine. Those panoramic films you do in dentistry, you know what they looked at? Carotid calcification. How many of you do those panoramic films? Do you ever see carotid calcification? And do you tell patients about that? It's not in your protocol that you need to, I understand that. But it might surprise you that a lot of patients would not know that they had carotid calcification, because they very much maybe, and probably are, asymptomatic, because they've developed collateral flow and so forth. But here's the reality. If they have carotid calcification, 26% of these individuals had a cardiovascular event within 3.5 years. A quarter of them had a cardiovascular event in 3.5 years, suggesting that patients found to have carotid calcifications on dental x-rays should be referred for further evaluation and aggressive management of vascular risk factors. Find a medical provider in your community who's going to listen to you and say, what? They have this? They have calcification in their carotids? Thank you, Tom Neighbors. Dr. Tom Neighbors, who's here for volunteering this picture. I am not, my training is not in to looking for this. I probably would miss it, quite frankly. That's not my skill set. I would say it looks like they're missing a tooth or two, right? That's probably not good either. But at any rate, that's not good either. So if you see something like that on a panoramic film, pay attention. That patient within a 3.5-year time span has a 26% chance of having a major cardiovascular event, because they're walking around with plaque. They don't even know it. Here's our cartoon for that. Look, the good news is your teeth look great, but the bad news is you have calcium in your carotid artery. So pay attention. You have an opportunity there to see something. I want to talk a little bit about carotid IMT. Carotid IMT is a technology that has been given to us from the American Heart Association. Well, it's been given to us for years. Dr. Gene Bond, Professor Emeritus at Wake Forest University back in the 70s, was doing this on rhesus monkeys to look at bad diets. And he started to do this on a study looking at these monkeys, and he was told to feed them terrible diets, like horrible fatty diets. And he was told to look at their arteries. And so at the time, they were doing carotid duplexes. They were looking at their arteries like this, and these monkeys were getting obese, they were dying, they were getting diabetes, and their arteries still looked like this. And he's thinking, God, they're dying. I mean, why aren't their arteries showing that? And then he thought, well, hey, I need to do something a little differently here. So what he did was brilliant. Dr. Gene Bond then took the ultrasound beam and he said, I'm going to look outward at these arteries of these monkeys as they're gaining weight, getting metabolic syndrome, diabetes, and I'm going to look at the wall of the artery. And what he found in these monkeys is that they were developing a ton of plaque, but it was in the wall of the artery. It wasn't like the duplex wasn't picking it up. So it was really interesting. That was way back in the early 70s. So in the year 2000, though, the American Heart Association said, here you go. Here's a test. It's called a Carotid Intima Media Thickness Test. Let's look at the wall of the artery. It's safe, it's reliable, it's reproducible, it's fairly cost effective. Less than $200, by the way. And it's valid. Here you go. Look for plaque, right? Is it covered by insurance 100% of the time? No. So that's the problem. If insurance doesn't validate it sometimes, people assume that it's not okay. Does insurance care if you have a heart attack or stroke? The most valuable patient for an insurance company is a dead one. That's true. That's the cheapest patient for an insurance carrier. It's a test to look for silent plaque that you're not going to feel. And my hope is you never feel it. Because what it's going to tell you, this carotid IMT test that I hope you get today, it's going to tell you what's the average thickness of this intima media interface. Because you know what? We know what normal is down to about age 5, all the way up to about age 85. We know gender differentiation. We know some ethnic variances. So it gives us a pretty darn good idea where your arteries should look like at your age, ethnicity, and gender backdrop. So if you are 50 years old, but your arteries look like an 80-year-old, I would stand up and take notice of that. It's also going to tell you something important. It's going to tell you if you have plaque building up in the wall of the artery. And if you have plaque building up in the wall of the artery even a little bit, you have a 40% chance of having a major cardiovascular event over 10 years. A 40% chance of having a cardiovascular event over 10 years. And you're not going to feel it until you have that event. But I'll tell you a secret, it's treatable. And you never have to have an event. You just need to know what you're dealing with. So don't stick your head in the sand and don't be afraid to get the test. Don't be afraid of the results. Nothing's better than finding it on paper. Oh my gosh, I have plaque? Whoa, I'm going to do something about that. Because your other option is having a stroke. Claiming your independence, drooping one side, unable to work, having a heart attack when you're on vacation. I could go on and on. We know a carotid IMT is predictive of stroke. We know a carotid IMT test is predictive of heart attack. So yes, the data supports what goes on here is also going on in the arteries of the heart, the aorta, the femorals. It's a window peek into the systemic system. I often think about it this way. If you have a map of the United States on the wall, remember those maps? Not just on your iPhone, but a map on the wall. And you look in the bottom right-hand corner, and there used to be a key, right? And it said, oh, if it's 1 inch here, then that's 100 miles here on the highway. Do you guys remember maps? Yeah. Okay, that's an IMT test. It's an IMT because it tells you what's going on in all of those highways. So what you find here is systemic. That's important to realize. So you're taking a picture of what's going on from head to toe. Is it perfect? No, it's not perfect. But it's one of the best tests we have. And the reason I say it's not perfect is, if I look here and someone has a family history or a personal history or something I'm concerned about, and I don't find plaque here, that's when I move on and I say, well, you know what, I'm going to do my homework a little more. I'm going to do a coronary calcium scan. I'm going to look downstream because the body usually protects the brain for as long as possible. So by the time you find plaque here, the data from the Rotterdam trial, the ERIC trial, etc., says what's going on here is systemic. But if you don't have plaque here, you could still have it downstream. So that's when I do a coronary calcium scan, or I'll look further down. But this is the best place to start. And there's no exposure to radiation. And the data would support, even September 12th, 2013, 5, 6, 7 months ago, the carotid arteries serve as a window to systemic atherosclerosis. Allows us to find plaque, find risk, and follow disease over time. Is your treatment working? Let's take a peek and see. Right? Should get better in there. We should see structural improvement. How about this, you guys? How about this? And then we're going to move on to root causes. What about you get an IMT today and you get your results back and you find just a little bit of plaque? I mean just a little bit. Not much to really worry about, but just a little bit. And you certainly feel fine and you have no intentions of dealing with it today because you know what? You got a lot going on today. You're busy. What about that? What about that? And you say, la, 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 I don't want to deal with it today. I've got too much on my plate. What about that? You know, that's been challenged. That's been studied. In 2001, the Café de Caves trial did that. It took 10,000 of us, ages 35 to 65 individuals, 40% women, 60% men. They did a carotid IMT, and they also expanded geography and looked at the top of the leg, at the femoral arteries as well. And they said, hey, we're going to look for plaque. And you know what? Back in 2001, this trial actually started in 1991. It was a 10-year trial. Let's pretend we're these 10,000 people. They said, your Framingham score, your calculator says you're fine. You all feel fine today, right? No shortness of breath, no chest pain, you feel fine, right? You're here, probably feel fine, I hope, right? Framingham says you're fine. You need to sign this paper today. It says, whatever I find on this test in the hallway, I'm going to not do anything about it. I'm not going to treat it. Because back in 1991, this thing was controversial anyway. I mean, what does plaque in the wall have to do with anything? It's not blocking blood flow. So it was a placebo trial. They just wanted to see what happened with these people, which could be many of us in this room. Here's what happened to these people who signed on the dotted line and got no treatment over 10 years. This trial cannot be reproduced. It would be unethical now. Class 1 were normal arteries. Why do I want to pause on that? Because most people had normal arteries. So if you walk around and you think, well, Amy, who cares? Everyone has plaque. I mean, this is a disease of aging. No, it's not. Is it normal to have plaque? Is it a normal stage of aging? No. Is it common? Yes. Heart disease claims more lives and causes more disability than any other disease state. But should it ever be considered normal to have plaque in your arteries? No. Should it ever be considered normal to have calcification on a duplex scan when you do that and find it on the carotid artery? No. It's a problem. Class 2, they had thickness but no plaque. Class 3, they had disease. I mean, just a little bit. They had a thickness in the artery wall that meant they had disease. Class 4 they had so much disease that the arteries were actually closed in one section, but the body had kind of rerouted the highway a little bit. This is the one that gets my attention because this is the one we see most often in asymptomatic people. Out of that group, if you had atherosclerosis or plaque in the artery wall only, you had a 40% chance in a 10-year time period of having a major stroke or a major heart attack. So wouldn't you want to know if you had plaque hiding in the artery wall? I would. Because if I did and I knew that that plaque was treatable, I could do something about it. So when you get your IMT, do not ignore it. Find out if you have plaque. So when we identify patients, we put them into 3 categories. One is, you don't have a cat in the gutter. And we look here, we look here, we look here, we look here, and there's no cat. My lifelong goal for you is that you never develop a cat in the gutter. Class 2 is, hey, or secondary prevention is, there's a cat in the gutter. My goal is that it will never leap out, ever. You will never have a heart attack or stroke to prove that there's a cat in the gutter. How great is that? That's my guarantee to you, matter of fact, if you're under my care. Class 3 is tertiary prevention. That cat's leaped out once, you've had a stroke, you've had a bypass, you've had a heart attack, you've had a stroke, you have a TIA. It's leaped out once. My job, my dedication to you is that it's never going to do that again. And I'm going to work every day, night and day, to make sure it never leaps out again. Ever. Do you think I want my patients who are here, or even here, to make sure they see their oral medical specialists routinely? Yeah. It's a critical part of their treatment. It's as important as their statin, as their blood pressure, as their exercise, as their sleep, as their diet. Because that cat can leap out in what condition? Inflammation, right? So let's talk about inflammation. So this is an artery, or at least our illustration of an artery. And inflammation can brew at the endothelial wall and at the intima. And I want to explain something about the endothelium a minute. So I want to give you a visual. Every artery that we have, whether it's the size of a human hair or as big as like a number 2 pencil, like the carotid artery, they're huge, right? Or the femorals, those are huge. So however big or small the artery is, they're all built the same. They all have an opening called a lumen. They're all lined with these endothelial cells. And the endothelial cells have a really important job. Their job is to seal themselves tightly together and provide the pavement for which blood can flow and prevent the activity underneath that endothelium from rupturing through that endothelium. And if you think about the dynamicity of that endothelial wall, my bias is it's probably the most dynamic structure in our body, both in function but also in size. If I was to pull the endothelial cells out of my body, and lay them out flat, do you know how many, and lay them out flat, I would have probably 5 tennis courts of surface area of endothelial cells. That's a lot. A lot. So when you start talking about these laboratory tests that can measure the activity of the endothelium, things like HSCRP, things like microalbumin creatinine urine ratio, things like fibrinogen, F2 isoprostane, myeloperoxidase, they're telling me clinically, what does my tennis court look like? Do I have cracks in that tennis court? Or is my tennis court like smooth as silk, which is what I want it to be, right? And then some of the tests measure underneath that tennis court. They measure what's going on underneath, and that would be the Plaque 2 test. That measures underneath the tennis court of what's going on where the plaque actually lives, right? That's lipoprotein-associated phospholipase A2 test underneath the tennis court. Inflammation via different genetic studies. There have been several, 2 major ones published in Lancet and another one published in Genetics Consortium, have shown us that inflammation is causal of 2 things, not just events, but actually causal of plaque development. That changed everything. Once we learned that inflammation is causal of plaque deposition and atherosclerotic changes, then we thought, hey, if we can cut inflammation off at the pass, maybe we can even prevent a cat from getting in the gutter. That's great. That's really, really important. Because we used to think inflammation's role was just to prevent the cat from rupturing, but now we know it goes both ways, which is really, really important. We have lots of tests out there to measure what's going on, you know, with the endothelium and what's going on with the intima. These are some of them. I measure more than this, but these are some of them. And I just want to give you a visualization here of which one of these tests are affected by periodontal disease. If your patient has active periodontal disease, I'm going to highlight in yellow the tests that will change. How do you think I feel about that? Do you think I'm skilled at treating periodontal disease? Nope. My job, my guarantee is to prevent heart attacks and strokes in my patient. And yet, I know that there's a condition out there that I can't treat. So I have a huge respect for oral medicine experts, dentists, hygienists who know how to treat periodontal disease, because it affects my world. And I know lab tests. I understand lab tests. I don't know how to do this, except on myself. I floss and brush. Yes, I use Sonicare, all that. But I don't know how to treat it for my patients. But I know it affects these labs. So the minute I see these labs go awry, I say, all right. What's going on? Is it your lipids? Is it your blood pressure? Is it your exercise? Is it your stress? Is it your sleep? Is it your diet? Is it your teeth? Is it your gums? You see my point? Let's talk about them just real briefly. HSCRP and fibrinogen are as predictive for heart attack as total cholesterol and HDL. So if you think for 1 minute that HSCRP or fibrinogen, which are acute phase reactants, meaning if I stub my toe, if I get a sliver, if I have strep throat, yeah, they're going to go up. But they are as predictive as total cholesterol and HDL as me having a heart attack. So yes, they are acute phase reactants, but they do have predictability, and that's important. So if I know something that can bring down HSCRP and fibrinogen, I'm going to do it. Just like I'm also going to treat total cholesterol and HDL, because those have predictability too. Here's the data showing total cholesterol, HDL, CRP, and fibrinogen are almost statistically within range, which is important to realize. So we cannot just assume that if we treat cholesterol, we have no issues. We need to treat the whole picture, including some of these biomarkers for inflammation. How about this concept for you? If you brush your teeth twice a day versus once a day, or less than once a day, you are going to have a difference in your hsCRP and fibrinogen. So here you go, dental hygiene students. So when you tell your patients to brush their teeth, you can say, oh, by the way, I want you to I want you to brush your teeth because it's going to lower your hsCRP and fibrinogen. Your patients might say, what? And then you can have a conversation. You can say, you know what that means? It means that your tennis court is going to be happier. And they're going to say, what? And they're like, huh? What? What are you talking about? And you can just talk to them and say, well, your tennis court is, you know, and go on and on and on. It's a captive audience, you guys. What is the lipoprotein-associated phospholipase A2 test, otherwise known as the Plaque test? It's a test that measures underneath the tennis court. And how many of us have a family member, a friend who's ever had a stroke? Do you know that the LPPLA2 test is the only FDA-approved test to measure your stroke risk? If you have a family member who's had a stroke, wouldn't you want to know what your Plaque 2 score was? Because you know strokes are genetic, so are heart attacks, so is atherosclerosis. Huh. When you want to know what your Plaque 2 score is? It was given approval by the FDA to measure ischemic stroke risk in 2005, 9 years ago. It was given approval to look for coronary heart disease risk in 2003, 11 years ago. It's not new. It's been around for a long, long time. We know that once it hits around 200 or higher, that cardiovascular event rates double. So if it hits 200, that's not okay. Now you can imagine here what's going on. We are treating something that the patient is not feeling. So we need some way to measure that activity. This is what's telling us what's going on underneath the tennis court. So if the tennis court's hot, plus the Plaque 2 is hot, we're going to wind up into a problem. You know what else? This Plaque 2 is not an acute phase reactant. It's not thrown off if you smoke. It's not thrown off if you have rheumatoid arthritis. It's not thrown off if you have asthma, sinusitis, COPD. It's real for underneath that tennis court within the intima media interface of the artery. It's a blood test. It's a non-fasting blood test. How about this? They even gave 32 probably starving dental or medical students endotoxin. They said, you feel good today, just wait a minute. We're going to give you this endotoxin. These people got so sick. Fever, vomiting, chills, awful sick. Then they measured their Plaque 2 and their hsCRP. hsCRP went up 100-fold within 24 hours. No change in LPPLA2. So if LPPLA2 is up, do not blame it on the fact that they have a sinus infection or something. Something is going on in the wall of their artery. So I'm sitting here telling you that rheumatoid arthritis doesn't throw it off. Endotoxins from some sort of virus don't throw it off. Do you know the only systemic condition that has been published to show it can cause an elevation in LPPLA2 other than oxidation activity within the artery wall? Do you know what that condition is? You got it. Periodontal disease is associated with elevated levels of LPPLA2. And that's important. So patients with periodontal disease were almost 2 times more likely to have LPPLA2 levels over 215. I just told you that if your level's over 200, you have a 1.7-fold increased risk of having a major heart attack. 37% of individuals with no cardiovascular risk factors except periodontal disease had elevated LPPLA2 levels. Now then, the question is there a cause and effect related to this? Meaning if we treat the periodontal disease, does the Plaque 2 come down? Because that's what really matters, right? It's one thing to say, oh, that's interesting, but if we treat periodontal disease, does the LPPLA2 level come down? And the answer to that is yes. I wish the FDA would say, if Plaque 2 levels are up, medical people, you better refer them to a periodontal expert who can treat periodontal disease. Find it and treat it. But people in medicine don't get it yet. They will after today, because you all are here. right? Periodontal disease can cause LPPLA2 levels to elevate, and treatment of periodontal disease can cause LPPLA2 levels to fall. I'm going to keep moving on just for the sake of time. Okay, so what causes inflammation and atherosclerosis? There are a lot of causes. We call them root causes. And we're going to still learn more probably as time goes on, but these are the ones we know of right now that we can deal with and treat, and there's lots of them. There's things like a genetically inherited lipid abnormality called lipoprotein(a), psychosocial issues, we talked about that, dysfunctional HDL and myeloperoxidase, infectious diseases, autoimmune diseases, vitamin D deficiency, et cetera, et cetera. I'm going to talk about just a few of them today. I'm going to talk about just one called insulin resistance, just to show you of the cross connection with insulin resistance and periodontal disease. I'm also talk about sleep apnea because I believe dentistry has a huge role in sleep apnea. And then I'm going to talk about the oral systemic connection and close it with a case. So we're going to talk about a couple of these root causes because if you go out there and you do an IMT and you find plaque, then the next thing you need to do is say, well, which one of these is causing my plaque? And if all you know is you have high cholesterol, I got to tell you something, that's one of a much bigger piece of pie. It's one thing of usually a lot of different things. So let's talk about insulin resistance first, real briefly. Insulin resistance damages the arteries regardless of blood sugar. So I'm not going to spend too much time on this, but I want you to start thinking about it. Because insulin resistance is often missed clinically. Insulin resistance is often, sadly, not picked up until someone has type 2 diabetes, which usually takes 20 years of someone being insulin resistant before they are told they have type 2 diabetes. So when you have type 2 diabetes, realize that those arteries have been beaten up, inflammatory rise for 20 years. You get that? 20 years those arteries have been beaten up. Insulin resistance increases arterial inflammation. They've looked at carotid disease with PET scanning. Or they've looked at people who are normal, people who've had failed glucose tolerance tests, which we do on everybody, and people who are already into a diabetic range. The longer they have been insulin resistant, the more likely they are to be diabetic, the more damage they've had to the arterial wall, as documented by PET scanning with inflammation. Majority of heart attack patients are insulin resistant and don't even know it. 8,000 patients with a heart attack without diabetes or impaired fasting glucose, followed for just 3 years. Within a 3-year time span, 62% of them converted over to diabetes. Brad and I often talk about this scenario because we both have patients who have said it. You may have heard us say this before, but we have patients who we meet for the first time and we're asking about their family history, their history, and they say, yeah, I was in the hospital, I had my heart attack, and it was just the craziest thing because when I was in there, I caught diabetes. And we're like, seriously? I don't think you caught diabetes in the hospital. I think your insulin resistance led to the vascular damage, which caused the heart attack, and you were just picked up to have, the diabetes was discovered. Or the other thing is, you ask people, do you have a family history of diabetes? And they say no. And you say, well, how old was your grandma when she died of a stroke? How old was your dad when he had his heart attack? People died before they had insulin resistance long enough to become diabetic. And the diagnostic criteria, the generation before us, you had to have a fasting blood sugar of 140. People didn't live that long to have a fasting blood sugar of 140 to be called diabetic. It's pretty simple, you guys. I mean, if you're in France and your blood sugar is 116, you're diabetic. If you don't want to be diabetic in France, fly to New York because it's cured, because you're not diabetic there until it's 126. It's a crazy scenario. Majority of heart attack patients are insulin resistant. 140 acute coronary syndrome patients without diabetes or impaired glucose tolerance. All of them, every one of them got a glucose tolerance test. I don't know why that's doing that. Is it my hair? 66% were either diabetic or pre-diabetic. So it's out there. How about this? Periodontal disease is associated with prediabetes. 1,100 roughly non-diabetic patients, 51% female, age range 30 to 60. They did a full mouth periodontal exam and also a glucose tolerance test, which I love. Periodontal disease was defined as either having none or mild, moderate, or severe. 75th percentile if mean probing depth was over 2.19 millimeters or attachment loss of greater than 1.78. That's a pretty aggressive cut point, isn't it? That's pretty good. Glucose tolerance was determined to be abnormal if it was greater or equal to 140. There was a significant increase of risk of impaired glucose tolerance, meaning failing their glucose tolerance test with severe periodontal disease compared to none or mild with the 75th percentile. So if you had this 75th percentile as documented by a probing depth of 2 millimeters or greater, you had a twofold increased risk of failing your glucose tolerance test. That's a big deal. And many people, dentists that I meet, who aren't educated, sometimes say 2 millimeters is normal. Maybe it is, I don't know. But the point is there is a association. This was adjusted for age, gender, smoking, calorie intake, alcohol, exercise, BMI, race, ethnicity, even education level, a lot of other things that could cause changes. Insulin resistance can impact all the inflammation as well, just like periodontal disease. Let's talk a little bit about obstructive sleep apnea for just a moment. Obstructive sleep apnea, when you look at meta-analysis, is a big, big deal. And I'm only going to show this one slide on this. 5 studies looking at over 8,000 people with OSA show that there's a 2.2-fold increased risk of stroke for people who have OSA, untreated OSA. 5 studies that recruited mainly men in this case. Significance for coronary artery disease, about 92% or twofold almost increased risk for even coronary artery disease. 2 studies with almost 2,500 OSA patients, significance for not just having a cardiovascular event, but dying from it if you had obstructive sleep apnea, odds ratio twofold. I put in here those that were statistically significant. This is what I love. If you actually treat the apnea, and this happened to be a CPAP study, but I'm a huge fan of the oral appliance if that's appropriate for the patient, and a good sleep lab will offer that as an option, in my opinion. But the point I want to make here, 2 points with this study. One, these people were elderly, so there's no time that you cannot affect this in a positive way. The worst case of apnea I saw was a woman who presented to me who was in her 80s. She was referred to me because nobody could get her blood pressure down. She weighed about 80 pounds. She was this big. No one could get her blood pressure down. And as I was questioning her, sleep kept coming up chronically for years. Sent her into the sleep lab. Dr. Coates called me and said, look, this is one of the worst cases of apnea I have ever seen. Got her apnea treated, able to pull her off some of her blood pressure medication. So don't just visualize who you think may or may not have it, and don't exclude people based on an age cut point. If you treat the apnea, the risk is mitigated. This is a very treatable condition. I love that. Okay, let's talk about periodontal disease and then close with a case. Why are we here today? Let's bridge this gap. And Dr. Neighbors is just escaping, but Tom, I just have to say, my whole education on this was introduced to me and my colleague Brad Bale by Dr. Thomas Neighbors. So Tom, you are, in my opinion, the guru of this whole connection. So thank you so much before you leave. And I really just have such a tremendous amount of respect for you, and I'm so thrilled that you're here, and I'm going to miss your talk today. So thank you so much for all of your work, lifelong work. And Dr. Neighbors and Brad Bale and I were working together in 2011, and we made a joint statement. And we called it Bridging the Gap, and now I see that that statement is being used here, and that thrills me. But we made this statement in 2011. We said, the three of us, we said, it is now time that medicine and dentistry bridge the gap and work together for the benefit of systemic wellness. The three of us made that statement in 2011. Remember that, Tom? Yeah. So what a thrill, isn't it, to see this? Yeah, it is. So let's talk about that. What is the link between vascular disease and oral health? It's really inflammation. The oral systemic connection, in my opinion, and many of us here, it is the key to optimal cardiovascular wellness. The American Heart Association agrees. They said there is level A evidence that what goes on here does affect the heart. There is level A evidence. That's the best evidence you can have, right? So do not question yourself in your thought process here and wonder. There is level A evidence, which is very, very promising and very, very exciting that we live in this era. The first time a joint statement was published, that was in 2009, when the American Heart Association and the American Periodontal Association published a joint statement that said, look, cardiologist, pay attention to what goes on here. And the dentist said, look, cardiologists, pay attention to what goes on, I mean, vice versa. They told each other to pay attention. It was a joint statement. It was fantastic. So what is periodontal disease? It's a chronic infection, and this is where my expertise wanes a little bit, but I'm just going to bring the medical folks up to speed with me on this. It's a chronic infection. There's two forms of it. We got gingivitis, and we also got this thing called periodontitis, which is chronic and can be quite aggressive. There's a number of subclassifications for this, and there still seems to be a lot of different definitions of what is periodontal disease. Is it attachment loss? Is it bacteria at a certain threshold? You know, what is the true definition? And that's why it's a bit challenging. But here I do know, and that is, if you do not have a tight connection between this part, the gum, and the tooth, and you get bacteria that can influx and communicate with these little capillaries, then we have a problem. And then it starts to tread on my territory from the medical side. Am I doing okay on that, Tom? Absolutely, he says. Okay, so that's where I get concerned, because if the bacteria that you all are so skilled at treating here gets into this little capillary system, it treads on my territory in medicine. And then I am supposed to know how to deal with it, because I see it on my lab reports and things like elevated HSCRP, elevated LPPLA2, blood pressure, lower HDL, A1C levels. And yet, I am not the one to treat periodontal disease. You are. So we need to work together on that, because I know for a fact that's not good. And I don't know how to treat that. You do. I don't. 3 changes occur. Homeostasis, increased pathogenic species, decrease in health associated with this, host immune response, acute phase, chronic, and there's genetic variations. Some people are obviously genetically predisposed to respond vehemently to an acute inflammatory response, and some people respond less vehemently. But at the end of the day, once you get loss of clinical attachment, there can be problems with that influx of bacteremia into the systemic system. Remember sepsis. It's a septic infection at that point, and that's problematic for overall systemic health. We in medicine get freaked out over this. Matter of fact, if we have a patient who has a foot ulcer, we are all over that. We think, oh my gosh, you probably have diabetes. Let's get you to the wound clinic. Let's get home health involved. Matter of fact, let's have a home health nurse come to your house every day and change that thing for you. We should be doing that for this, because it's the same deal. I'm sorry that we've let you down in medicine. We have, because this is as important as this. And yet in medicine, we don't give it its proper attention. And I'm embarrassed about that, but that's the truth. And we need to do a better job. We're trying. But we're all here, and that's what we're here for, right? Yeah. So why are we talking? Is there evidence to support periodontal disease is associated with vascular risk? Yes, there is evidence. Let's be scientific about this. 11,000 people, mean age 50, followed for 8 years, 555 cardiovascular events, poor oral hygiene or equals never or rarely brushed. Hazard ratio for having a cardiovascular event was 1.7-fold with a p-value of less than 0.001. Yes, there's evidence that if you don't brush your teeth, you are at increased risk for a cardiovascular event. What about oral hygiene associated with cardiovascular risk? This is the one I showed you earlier. depending on how often you brush, is associated with cardiovascular events. I showed you the earlier one with hsCRP and fibrinogen. This teases it out to events. What about even other risk factors like HDL? Is periodontal disease associated with risk factors like cholesterol? Yes, it is. For people who have chronic periodontitis, they tend to have lower HDL levels. What is HDL's job? HDL is your good cholesterol. Its job is reverse cholesterol transport. Get the oxidized LDL out of the intima media interface into the liver, get rid of it out of our body. If you have a chronic infection, you can't do that very effectively, can you? What about glycemic control? If you have chronic periodontitis, a chronic infection, your likelihood of having increased sugars, your likelihood of being able to heal is not as good, not as substantial. A1C change versus the treatment group versus non-treatment group for periodontitis was minus 0.4%. So it actually lowered A1C levels for people who got good periodontal disease. Again, I wish the FDA would approve periodontal disease treatment to affect A1C levels. Then people in medicine would stand up and take notice. That would be great too. How about hypertension? How about blood pressure? Do you know that in this particular study, 653, quote, healthy people over age 55 were tested for 4 bad bacteria? 4 bad bacteria. The highest burden of bacteria versus the lowest burden of bacteria. And the interesting thing about this study, it did not matter what their gums looked like. Let me repeat that. It did not matter what their gums looked like. It was a burden of bacteria study. And if these individuals had bacteria above threshold, they had an increased likelihood of 3-fold of having about a 10 millimeter of mercury increase in their systolic blood pressure. Do you realize that? If someone comes in with a blood pressure that's 10 millimeters of mercury higher on the systolic, I, in medicine, am forced to put them on a blood pressure medication. What about the idea of treating those bacteria and allowing that blood pressure to fall naturally instead of that individual winding up on a lifelong medication that maybe they don't need? I mean, wow. And the whole issue here, it was the concentration of the bacteria and not the clinical diagnosis of periodontal disease, which correlated with the blood pressure. That gets my attention because you know what? How do I know if my patient has these pathogens? How do I know in medicine? You know what I'm very skilled at? Reading lab reports. I read them all day long. In medicine, that's the language we talk. We don't say, what does your blood pressure feel like? What does the arm feel like? We say, what's your blood pressure numbers? I want to know what your pathogens are. If you say you go to the dentist every 6 months, show me you have no pathogens. And I want you in dentistry to show me that the periodontal treatment your patient is getting, my patient is getting, is effective. How do I know it's effective? Because I want the report. Show me the report. Because that data I just showed you says if any of these pathogens are above threshold, they have a chance, a 3-fold increased risk of having blood pressure 10 millimeters of mercury higher. So get the report for your medical provider and educate them how to use it. And if you don't get the report for me, I'm going to send my patient to a different dentist to get it. It's that simple. I will, because I need the information. Evidence that periodontal disease is associated with vascular disease. Is there evidence for that? Yes. The INVEST trial looked at overall periodontal bacteria burden as related to carotid IMT, that test that you're going to get today. The relationship was specific to causative bacteria again. PG, TF, and TD, the mean IMT values across the tertiles. The dominance was increased, so the more bacterial burden there was, the worse the IMT was. So yes, there's a direct relationship to atherosclerotic changes. Yes? Yeah, I think you'll talk about it more today, and I think there's more than one report. There's a couple different companies, right, Tom, that do the report. but it's a DNA analysis to look for these bacteria. Tom, are you going to talk about that later today? Yeah. Evidence that periodontal disease is associated with cardiovascular events. Let's look at this briefly. Porphyromus gingivalis, PG, was associated with predicted for acute heart attacks by 13.6-fold in 54 patients with acute MI. They analyzed AA, PG, TF, and PI. The likelihood if they had PG, there was a 13-fold increased risk. They adjusted for the other things that could cause acute coronary syndrome, like lipids, taking statins or not taking statins, plaque index, BNI, blood pressure, smoking, gender, age. If PG was present, there was a 13-fold increased risk of that patient having a massive acute coronary event. Do you think I want to know if my patient has PG? Can I tell by having them open their mouth? No. Do I need a report to tell me if it's there? Yes. Can I order the report? You need to order the report for me so we can work in partnership. How does these periodontal pathogens get into the artery wall? There's a couple different reasons or whys. Toll-like receptor is one way. Toll-like receptors recognize patterns conserved on pathogens. They include lipopolysaccharides. So toll-like receptors are part of, obviously, our innate immune system, allowing cells to identify harmful substances and can send out kind of an alarming signal and say, hey, 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 we have a problem here. Well, one thing I just want to touch on briefly, periodontal pathogens are a exogenous, I should say, lipopolysaccharide is an exogenous toll-like receptor, and periodontal pathogens can start that whole cascade. So that's one way, which is important. The activating stimulus for this, which would be periodontitis, is a chronic inflammation which will ensue. Sustainable toll-like receptor activation is maladaptive. So once the infection is continuous, it becomes a maladaptive result, and the result is inflammation systemically, and that's a big problem. What about spot-on toxic damage to the artery wall? That's a problem as well. I'm rushing through this so I can get to my case. But AA generates a leukotoxin. Leukotoxin can spot on kill, damage, erode, make a mess of that tennis court. So that's a problem as well, because if your tennis court looks pristine and you have this bad bacteria on board that creates this leukotoxin, then we have a huge problem. Numerous detrimental effects were noted from this: decreased proliferation, apoptosis, and VCAM and ICAM were increased. What about direct invasion into the artery wall, like diving through that tennis court and getting into the artery wall? Yes. FN is a bad player as well, because it creates almost like a bridge. It can lodge itself on that endothelium and allow the other bad boys to get in, almost like, come on, I'm here, I'm attached, come on in. So it creates like a bridge. It's like the leader of the gang and allows them to come in. So you want to know what you're dealing with here, because all of these bugs need to be treated sometimes differently than others. That's your world of expertise, not mine. 44 patients had coronary endarterectomies. 39 of these patients had periodontal disease. 36 of the 39 with periodontal disease, periodontal disease patients' plaques were positive for the pathogens. They did the DNA testing. They looked for AA, PG, TF, PI, and PN were detected. 2 or more periodontal pathogens were found in 64% of the plaques. This is in coronary endarterectomies. They found these bugs that are supposed to stay in the mouth in the plaques within the arteries of the heart. Do you understand the significance of that? That's not good, right? Suggests that periodontal pathogens in coronary plaque is not coincidental. What about in carotid plaque? 42 carotid endarterectomy specimens were analyzed via DNA, again, via periodontal pathogens, PG, AA, TF, and FN. All of the carotid plaques had at least one of those bad guys, and many had multiple. So again, what goes on here, gets in here, gets in here, gets in here. That's not good. What about endodontic disease? Really quickly. 101 people having a heart attack. Having a heart attack. 76% were men, average age 63. Obstructive blood clot and arterial blood analyzed by PCR for oral pathogens. Bacterial DNA load was 16 times greater in the thrombi than in the arterial blood samples, suggesting that the dangerous pathogens actually get in the clot rather than float around in the bloodstream. The oral streptococci were found in 78% of the thrombi. The periodontal pathogens were found in 35% of the thrombi. These are in the clots that cause the heart attack, you understand. 30 patients then underwent CT panoramic imaging. 50% of those patients demonstrated periapical abscesses that, you know what, they did not feel. So out of these 101 heart attack patients, here, 50% of them had a periapical abscess. If the patient's thrombus was positive for strep viridans DNA, they were 13 times more likely to have a periapical abscess. Odds ratio 13.2 with a p-value of 0.004. Then they looked at electron microscopy performed in 9 of those thrombi. Bacteria-like structures detected in all 9 of the thrombi. Whole, live, active bacteria were found in 1/3 of those thrombi. So if you think for one moment that what goes on in here can find its way into the artery wall, through the artery wall, into the plaque, create an inflammatory response, cause a plaque rupture, become part of that thrombus, stops the flow of blood, causes death, then you're not speaking the same language. Periodontal disease, endodontic disease, causes people to die of heart attacks. So your work is life-saving. So don't forget that. Conclusion, dental health and dental care should be one major element in preventing heart attacks. Any hospital that treats heart attack patients should celebrate every single dental office in their community. And there should be brochures in the hospitals, and every single heart attack patient should be referred to a good dentist and hygienist who know how to deal with this stuff. Pathogens should be measured, they should be treated and remeasured. It's almost malpractice. If 50% of acute heart attacks could be triggered by an endodontic infection that the patient doesn't feel, it's almost malpractice to not make sure that periodontal pathogens, endodontic pathogens were not contributory to that thrombotic response, in my opinion. All right, so let me close with a case. It won't take long, but I want to show you, I want to introduce you to somebody. You okay so far? We're going to be done in 5 minutes, okay? This case I'll call pneumonia. Really? Really pneumonia, huh? This is Julie. She's 37 years old. Here. She's pretty, isn't she? She looks healthy, doesn't she? She's fit. These are Julie's words. I went to the emergency room and I was so surprised to find out that I had pneumonia with no fever, no cough, and no respiratory symptoms. Let me tell you about her. October 6, 2011, she went in with shortness of breath and fatigue. The GP told her, "You have pneumonia." She was not given a chest x-ray, no blood work, no EKG. October 7th, the shortness of breath and it was getting worse. And she said, "Oh my gosh, you know, this shortness of breath is worse. Now I'm like really feeling anxious." The ER then said, "Well, maybe your antibiotic isn't working. We're going to give you a different one." She said, "But I don't even have a cough." And they said, "Well, you know, pneumonia is weird. It can happen, you know." And she said, "Okay." And she was sent home with now a cough medication, a different antibiotic, and she was scratching her head like, "Man, I don't get this." October 13th, a few days later, she went in again. Finally, they thought, well, maybe it isn't pneumonia. They did all kinds of tests now. They did an echo, EKG, chest x-ray, abdominal CT, spent about $45,000 to find, wow, Julie, you haven't had one heart attack, but you've had 2. And you know what, Julie? You better get in here sooner next time. And she said, "Are you serious? Are you serious?" Why are we unique? What are the symptoms that we as women experience, girls? Prior to a heart attack, Dr. McSweeney asked 515 of us, "What did you feel like a month before you had your heart attack?" You know what women said? Unusual fatigue, sleep disturbance, unexplained anxiety. Can we discount those symptoms to like things like perimenopause, oh, I don't know, life, like working motherhood, right? At the time women had their heart attack, here were the top 3 symptoms: shortness of breath, abdominal pain, and sweating. What do you not see up there? Chest pain, jaw pain, arm pain, elephant on my chest. Here's my advice to you. If you feel differently than you ever have before, consider the idea that it could be your heart. If you feel differently than you ever did before, consider the idea that it could be your heart. Heart disease kills more women than breast cancer tenfold. So consider the idea it could be your heart. Let me introduce you to Julie. She's 37 years old, mother of a 3-year-old daughter, 5 foot 6 inches tall, 153 pounds, weighs 37 inches. Initial visit to see me was after she had not 1 but 2 heart attacks, asking the question, why on earth did I have a heart attack in the first place? She had no idea. I wanted to say, okay, I want to start from basics. I want to know why you had disease. And matter of fact, I want to tell you what caused a heart attack. She didn't even know what happened. I said, do you know what happened when you had your heart attack? She goes, yeah, I must have had high cholesterol that blocked the flow of blood. I said, no. You had a clot. And she said, I did? She didn't even know that. When she understood this whole concept, she understood why she was fine one day and not the next. And then she started to ask me, well, is there any testing, Amy, that you can do to make sure that this won't happen again? And I said, oh, yeah, there is. We can do inflammatory testing. We can do structural testing. We can do an IMT every year to make sure you're getting better. Oh, yeah, we can. Did she say, well, will my insurance cover that? No. She didn't ask that once because she had just spent $45,000 for trying to figure out it wasn't pneumonia. Could we have picked Julie up years before she had a heart attack just by looking at her health history? Yeah, I'm just going to cover these quickly. She had migraine with aura. She had PCOS. She had preeclampsia when she was pregnant with her 3-year-old daughter. What caused her disease, though? What was the true cause of her disease? I have a 73% chance to blame it on insulin resistance. I couldn't blame it. I couldn't give her the diagnosis. She didn't have metabolic syndrome, didn't have a triglyceride HDL ratio was off, her fasting blood sugar was fine, but you know what? She flunked her glucose tolerance test. Yes, she had insulin resistance. She also had a lipoprotein A abnormality. She had a vitamin D deficiency. She was KIF6 negative, which is a gene. She had an ApoE4 profile. She was 9p21 genetically predisposed. She had anxiety. According to her dentist, according to her, she had no dental issues, which I later then did ask her dentist to do the oral DNA, and she was negative for oral DNA. So that was good. So no pathogens. Lipids, she didn't even know what her lipids were prior to her heart attack. She was 37 years old. No one had ever checked them before, which is not that uncommon, by the way, for a 37-year-old. But all of these reasons were not addressed. Now, it cost me about $187 to check all those. Did insurance pay for it? Yeah, they did after she had a heart attack. Would they have paid for it prior to her having a heart attack? Probably not. But would it have been a good investment for her to have known that? Yeah. The other question I have, would her medication she left the hospital on treat all of these things? No, it wouldn't. Okay, so if her medicine's working, she should have no inflammation, right? If her treatment she's on right now, after having 2 heart attacks and getting treatment in the office, if her medicine's working, she should have no inflammation. Because that's how you know if treatment works. It's not just knowing if the lipids look pretty or the blood pressure looks pretty or if your weight says you're at a certain level that's good. You want to know if you have no inflammation, right? So I'm going to check her inflammation. Is the current med, sleep pattern, stress management, diet, all of that working, Julie? Let's check your inflammation. F2 looked good, endothelium, HSCRP. I'm not happy unless it's less than 0.5. Microalcreatinine urine ratio is over 7. You know what that says? 5,181 men and women followed by the Framingham risk cohort study, mean age 55 plus or minus 11 years, followed for 6 years, says if I let Julie's microalbumin creatinine urine ratio stay above 7, she's got a 2.92-fold increased risk of having another event. So I want that less than 7. Fibrinogen's okay. What about underneath the tennis court? I am most comfortable if it's less than 180. The data for acute events is over 200. The data that says there's nothing going on with that intima should be less than 180. So if it's over 180, I'm saying, hey, something's going on. 204. So what freaks me out about her right now, she's on treatment, she left the hospital, she's been on treatment for a while, about 3 months, and they say, hey, if it happens again, you better come back sooner. She's like, wow. So her tennis court's hot, and underneath the tennis court's hot. Do you think that cat's going to jump out again? It sure could, right? All right, HSCRP was up. Microalcreatinine urine ratio was up. LPPLA2 is elevated. It is associated with plaque inflammation. The cat is going to jump again unless I figure out why those inflammatory markers are up. I figure I know why those inflammatory markers are up because no one's treating her insulin resistance, no one's treating her lipoprotein A, no one's addressing the fact that she's genetically predisposed with a 9p21 KIF6. No one's dealing with any of that, nor her anxiety or her ApoE4 genotype, so she's gotten crummy advice for lifestyle. It's not rocket science. So I did an IMT. Not to prove to me that she has plaque. I know she has plaque. She's had 2 heart attacks. I didn't do an IMT to tell me she has a cat in the gutter. I did an IMT so I had something to follow. I want to follow this disease in a way that Julie never feels it again. So I want to peek into her arterial system and follow it every year so I know that this is getting better. I know this plaque is getting better, maybe even going away. That can happen if you do your job right. Here's her initial IMT. She had soft plaque. Of course she had soft plaque. She's 37 years old, just had 2 heart attacks. I would expect her to have some soft plaque. But wouldn't it have been nice if she was at a conference like this and had an IMT in the hallway and said, Julie, you just have a little bit of plaque. And she knew that at age 35? And then at age 35, someone had the wherewithal to say, wow, that's not okay that you have a little bit of plaque. We better find out what's driving that plaque. And they treated the Y and the cat never did jump out. That would have been great, but that didn't happen. Her missing diagnoses would have allowed her to be another statistic. She would have had another heart attack, just like 470,000 Americans. The mortality rate has been increasing on average by 1.3% per year since 1997. She'd have been another statistic. Her missing diagnoses that would have allowed these statistics are insulin resistance, lipoprotein A, vitamin D deficiency, ApoE4, KIF6 negative, anxiety, and 9p21. Treatment. Just going to whiz through these because I want to get to the dental piece. Statin, aspirin, ACE, yes, omega-3, lifestyle, and oral health. She only saw her dentist about every 6 months. I upped the ante for that with no hardcore data on my side, but I said, look, I want you to have nothing that's going to tread on our territory. I need you in there every 3 months, not every 6 months, and use Sonicare, floss twice a day. Please, oh please, oh please. And she said, fine, no problem, I'll do it. I had no idea that it was that important. I'll do it. Great. I wanted to treat her root causes, all of them. I wanted to get those treated, for which I did, which is all great. So let me just show you what happened here. This is real life. I see Julie every 3 months, but just to make it succinct, I just shortened it to year 1 and now currently. So lipids, her ratio is great. That's total cholesterol to HDL, 2.6, 2.2 to 2.1. Then lipoprotein A is better, ApoB is better. That's all fine and dandy. NT-proBNP, her heart muscle's getting happier, went from 266, 194, 159, that's great. Blood sugar looks good. I'm going to repeat her glucose tolerance test. But here's what's weird. So first year, everything's great. I mean, I initiate treatment and her HSCRP comes down, microalgae starting to come down, LPPLA2 comes down. And I'm like, man, what on earth is this? CRP jumped up from 0.5 to 37.6. And LPPLA2 went from 154 to 287. Thinking, man, this is not good at all. At all. So I'm going to show you a little bit of a video, and then I'll show you what happened with her. I have to do this because it didn't work. But that's okay. I'll do it right here. Inflammatory markers. And Julie is a patient of mine that I met, unfortunately, after she had a heart attack. She actually had 2 heart attacks, believe it or not, at the age of 37.
I was getting ready for work one morning and probably running a little later than I wanted to. So I was getting ready, and I remember feeling rushed or being rushed, but the feeling was all in here, and then it just kept compounding. And this heaviness, I wasn't breathing deep, a heaviness was just resting on my chest, and I couldn't make it go away, and I couldn't feel better.
Julie went in with chest discomfort. They told her she had pneumonia. And she said, well, I don't even have a cough. How could I have pneumonia? And they said, well, take this antibiotic and let us know how you feel in a few days. So the next day, same thing, the chest pressure is worse. So she goes in, and this was just last year. This isn't in 1957. This is in 2012 in a metropolitan city. She goes in again, and it wasn't till her second visit that they finally determined that indeed this poor 37-year-old mother of a 3-year-old daughter is having a heart attack. So she's treated now for her vascular disease, but when she first came in to see me, the tears and the issue were not because of pain, it was because of fear. She had no idea why on earth she had a heart attack. Why would she? She's a beautiful, fit, healthy 37-year-old mother of a toddler that says she's been told she's healthy her whole entire life. Why on earth did she have a heart attack? And so with the knowledge that we have of what causes vascular disease, it was with that education and that knowledge that Julie finally understands what caused her vascular disease, and we're treating that, and we're measuring the inflammation to know that our treatment is working, so she can proceed with life in confidence to know that that won't happen again. Most recently, however, I was doing Julie's inflammatory labs, and all of a sudden I saw a spike. Some inflammatory labs can be thrown off if you stub your toe, if you have a sore throat. This one really means something. It's a player in the disease state. So when this lab value is elevated, it tells me objectively that something is starting to tread on our territory of vascular stability. So that's when I pulled Julie in the office and I said, gosh, do you have anything inflammatory going on?
She said, this inflammation has got to be coming from somewhere. What is going on inside of you? She said, are you sick? Did you sprain an ankle? Anything? And I said, no, nothing. And she said, do you have a tooth that's bothering you? And I said, yes. Yes, I do.
And I said, well, let's investigate that further. Let's go back to your dentist and let me call your dentist. So that's indeed what I did, and we talked, and I said, this inflammation is being driven by something other than the common vascular risk factors that I'm treating for Julie. Can you please look a little deeper into that tooth that's been bugging her? Sent her to an endodontist who ended up doing a root canal, and it was found out that that tooth was horribly infected. Now the root canal has been treated, she's got the infection eradicated, and then doing her repeat inflammatory labs, I can now see that the inflammation is now mitigated, and onward we go. But it was really that tooth infection that really drove her vascular risk. And for someone like Julie, who had a heart attack unknowingly, we want to make sure that we just erase any chance of any vascular inflammation, including the oral systemic connection. So that's Julie, and I'll just close and show you how she's doing now. Okay, so the other thing I will tell you that wasn't in the film, and that's Gary, Katie, and Jeff Roldan's film called Say Aw. That's a snippet from their film. And so thank you for letting me show that, Jeff and Gary. But the other thing I did with Julie is I also upped the ante on my part clinically. When I see an acute inflammation like that, it was getting her to the dental component to make sure that infection was taken care of from that side. I also upped the ante as far as her medical management as well. I increased her statin, increased her niacin, and then I started to recheck her inflammation. I want to show you what happened. February 4th was when those numbers went awry. Then she got the antibiotic, the root canal treatment, all that stuff. Look what happened, though, to her inflammation. So 2-4, a month later, the inflammation started to drop dramatically. CRP went down to 3.2, plaque 236, 5.7, 2 months later, now down to 1.8 and 218. Then 8.8 in the summer, 0.7 and 160. So I am convinced, I am convinced that if she, and it was, you know, I had to probe a little bit. Are you sure? Like, are you sure? A tooth, like, is it sensitive? Is it whatever? And it was that, whatever you call that, periapical abscess thing that, I mean, thank goodness her dentist was great and kept pursuing it with me, but I'm convinced she would have had another heart attack. And she may have been 50% chance it would have been fatal. She was a little baby at home. So then, just so you know, I do follow her with an IMT. Is her treatment working? Her plaque is mitigated, you guys. Doesn't mean that her plaque is gone, but her IMT definitely shows that systemically she's getting healthier. So the chance of Julie ever having another stroke or heart attack is nil. I tell her, what are you going to do till you're 100 years old? Live your life, Julie. Let me do my work, you live yours. Just I'll see you every 3 months, forever. She'll be okay, though. She will be okay. She will live well with vascular disease, for sure. So that is my story. I do believe disasters can be avoided if we work in partnership together. So it really is a true honor, and I do think we do need to work together. And I am serious what I said. I do think all hospitals, and Tri-Cities is set up perfectly. All hospitals need to make sure anybody entering in with a cardiovascular diagnosis need to partner with the dental community. They've got to. Otherwise, they're missing the boat. Yeah, it's a great question. Yeah, I'm going to repeat it because it's a good question. Does chelation therapy have any room in what we do, the Doneen method? It's interesting. The chelation has gained enough traction that the NIH is formally looking at it right now in a study. What chelation has not been able to do at this point is give us enough evidence to show it's not going to destabilize already calcified plaque. Remember, what we're trying to do is stabilize atherosclerosis. I don't know yet because we don't have the data to stand on. Chelation, the premise is similar to what we're trying to do, right? But the challenge is that process going to reactivate? And they've not done studies to look at LPPLA2, HSCRP, microalcreatinine urine ratio, coupled it with IMT, coronary calcium. They've not coupled it with that. There's a lot of anecdotal evidence, enough so that the NIH is formally looking at it as we proceed forward. So not yet, but I'm watching the data. Okay, I think my time is up, so thank you all very, very much. Thank you.